salivary gland masses, because when I tried to use that system a few months ago, I already picked up a few the parotid and submandibular mass. And how can we differentiate between like a warfarin or pleomorphic or some sort of carcinoma in that one? Any experience on that?
I love this question, and there are some preliminary data. We have heard from Professor Richard Barr about the thyroid. A little bit the same result in the salivary glands, a little bit better as for the thyroid. But up to now, the evidence is very low. We use it in almost all patients, and the differentiation of that very important differential diagnosis might be a little bit better in the salivary glands, but it's not a yes-no answer, and we will learn together, all together, about to publish papers about the use in salivary glands in the future. It's promising.
Opinion of Professor Richard Barr about the salivary gland.
I agree. So the majority of the tumors are stiff, even if it's a Warden tumor in our experience. So I would never cancel a biopsy based on the elastography similar to the thyroid. The stiffer it is, the more likely it is going to be something malignant. We've seen a lot of cases where the patient we thought was a salivary gland, it turned out to be a squamous cell carcinoma. Those tend to be much stiffer than the salivary gland tumors. But again, I don't feel comfortable changing what I do based just on the elastographies.
So just to add, the last time we had disagreement was 120 years ago.
Ok, có câu hỏi gì thêm không? Thì không có câu hỏi gì thêm thì để cho hai giáo sư làm thực hiện cái demo để mọi người hiểu cái kỹ thuật về elasto. Đấy thì chiều hôm nay thì cái session liên quan đến kỹ thuật siêu âm đàn hồi mô. Đây là kỹ thuật tương đối mới và nó mở ra một cái ứng dụng rất là rộng rãi trong các lĩnh vực khác nhau. Thì ban tổ chức năm nay thì mong muốn đưa đến những cái kiến thức về cái kỹ thuật đàn hồi mô này cho mọi bác sĩ trên mọi miền đất nước. Tại vì hiện tại cái số máy đang sử dụng trên đất nước chúng ta còn rất là ít. Một vài trung tâm lớn có những cái máy này để sử dụng những cái máy này. Thì hôm nay chắc là mọi người buổi chiều hôm nay mọi người đã trải qua từ cái kỹ thuật những cái nguyên lý cơ bản, các ứng dụng khác nhau và cho đến mở ra một cái chân trời như cái bài cuối cùng của giáo sư District để cho mọi người thấy rằng là kỹ thuật siêu âm đàn hồi mô còn ứng dụng, còn tiếp tục ứng dụng hơn nhiều hơn nữa. Đây là một cái lĩnh vực mà trong ban tổ chức đang là đắn đo những năm trước, bây giờ năm nay mới đưa vào chương trình và mời được hai giáo sư hàng đầu thế giới. Những hai vị này thì nếu mọi người đi vào trên cái guideline của Vsum thì hai vị này là từng là những cái vị mà nằm trong một cái là panelist, tức là những cái chuyên gia của toàn thế giới được của tổ chức Vsum mời lại ngồi họp với nhau để đưa ra những cái hướng dẫn guideline về kỹ thuật siêu âm đàn hồi mô. Và ban tổ chức chúng tôi đã mời được hai vị này về đây để cho chia sẻ những cái kiến thức, những cái kinh nghiệm của hai vị đối với cái bác sĩ siêu âm Việt Nam chúng ta. Và hy vọng rằng sau khi buổi chiều hôm nay mọi người có một cái nhìn nhận mới về kỹ thuật siêu âm đàn hồi mô, và hy vọng tương lai những năm sắp tới đây, những tháng sắp tới đây thì cái kỹ thuật siêu âm đàn hồi mô được mở rộng ứng dụng trên toàn cõi Việt Nam. Đây là cái mong muốn của cái ban tổ chức trong buổi chiều hôm nay. Nếu có câu hỏi gì thêm thì sẽ mời hai giáo sư làm cái live demo trên cái máy. Now we have no discussion up to now, so we would like to both of you do examination in the live demo in the machine.
Okay, so I think what I'm going to do is start by showing you the things you can do wrong and prove to you the things that we've said are true. So we'll start with this breast phantom. So with the small parts, one of the problems that we have is the organ is not flat and our probe is flat. So to apply standard pressure that's uniform throughout the transducer, it's sometimes very difficult. So we rotate the breast patient and try to get the breast in the area we're concerned as flat as possible. So we rotate the patients a lot. So usually if it's in the medial portion of the breast, supine is okay. But if the lesion is lateral, we have to rotate the patient up and try to get it so that the breast is flat as possible. Because if you try to push pressure here, just like we've talked all along, if you've got an organ, I'm putting much more pressure in the middle where the transducer is and much less on the end. So let's find this lesion. So again, we talk about pressure. When I mean by pressure, you can watch the lesion. Let me turn on the pointer. So here's the bottom of the lesion, and watch what happens when I apply pressure. So you can see that I've moved the lesion way up high, and what we're going to do is we're going to go into elastography, VTIQ, and let's do a measurement with a lot of pressure. And you can see we've got a stiffness area here that's 5 meters per second. So now what I'm going to do is I'm going to now lift up the probe and see how the lesion is dropping. You can see that I'm releasing the pressure. And now you can see I'm starting to lose contact. So I'm just going to stay right here where I still have contact. And we're going to do another measurement. So now you can see instead of having a high value of 5 meters per second, it's about 3.5. So I've changed the lesion from a benign lesion to a cancer by just putting pressure. So it's very important that you always apply very little pressure. And that goes for all of the organs that we've talked about. Another problem we can have is if you don't apply uniform pressure. So what I'm going to do is on the right side of the image, I'm applying more pressure. So we call it heel and toe, the transducer. So I'm putting a lot of pressure on one side and no pressure on the other. And when we do our 2D shear wave, you can see that the left half where I'm applying more pressure is again very stiff, almost 5 meters per second, where on the other side where I'm applying less pressure is only 2.3. So we can make huge differences by applying inaccurate pressure. If we go to strain imaging, again, I'm not doing very much here, but sometimes what you may want to do is if you have a very big breast and you may not get a lot of motion from the patient, you can just apply a little bit of pressure. And if you look at the B mode image, you can see I'm wiggling the lesion and I can make the elastography better. So again, whichever system you have, you need to be able to find the sweet spot of where you're doing the examination to get a very good elastogram. And again, I'm not applying very much pressure. And again, you try to apply this so we don't have many artifacts. And then when we want to do our size measurement, the system will automatically allow you to do that because it copies it over and then you can go to this side. And since this is a phantom, it's not going to be anything but 1. But if this was a cancer, on this side you would have been able to see that it was bigger. Now, one of the things you should look at when you see this pattern, where you tend to have, I call it the worm pattern, it looks like things are changing and it looks like worms moving all over, that's all noise. And you'll often see that when here again what we have is, I have now only got the background tissue. There's only one tissue type. Everything is the same stiffness. So the machine doesn't know what to do because there's no difference. So you often get this noise pattern. And again, if you apply too much pressure, in a real person, it's hard to do in the phantom. You'll get, again, this pattern that looks like flickering white and black areas. That is just noise. So again, I think the important point here is you can see that by doing things wrong, I can get any value you want from a value. So you have to be very uniform technique and very good technique to get consistent results. Let's see if we can. Nice bullseye. This isn't the greatest bullseye in the world, but you can see we've got, for this cyst, a black outer rim, a white inner dot, and a white distal dot. This is very useful examination because, like I said, if we see that this is nice and round, there's no abnormal or deformity of this, we can say that this is a benign lesion. The other thing is we get this artifact because it's telling us that all the fluid in here is moving. So we call it decorrelation. The system, when it goes from frame to frame, doesn't know what happened. So it gives us this artifact. So in Siemens and Philips, we get the bullseye. In the other systems, we get the blue, green, red artifact. And if this material is very viscous, so if you had very thick, viscous material, you would not get the bullseye because the fluid has to be moving to get the bullseye artifact. So sometimes what may look like a very simple cyst, when you do this, if you can't get the bullseye, that means if you go to aspirate it, it'll be very difficult because the material will be very thick and very hard to aspirate through a needle. So we talked about the quality map. So I'm going to go back to VTIQ. And I'm going to go to the dual screen, so it allows us to see this, and I'm going to hit update. Okay, and now we get our image. What we can do is, one of the buttons on the bottom here, the fourth one from the left, it says velocity. So this is giving us a plot based on the velocity. So from 0.5 to 6.5 centimeters per second. Now, in breast cancers, we've had cancers that are above 10 meters per second. So there is a maximum velocity button, which is the third button, that we can increase the scale up to 10. And on this system, 10 is the maximum we can go. If the value is higher than that, it'll say high, meaning it's greater than 10 meters per second. So again, the default is 6 or 7, but depending on which probe, etc. But if you have this and you did your measurement and it said high, then you could go ahead and change the maximum velocity to get it to be within the scale. The other thing is we have this, again, this is the velocity map. I'm going to increase the value to make it look a little bit different colors. And then we also have the quality map. So this is like a traffic light. Green is go, yellow is caution, red is stop. So this is telling me, because it's nice and uniform green, that the shear waves were very good. So they were very strong, the displacement was very good, they traveled through things the way we would expect, and we can believe that those are good shear waves. If we had an area, so like in breast cancers, when I talked about we have soft cancers, you'll see on this map that it'll be red, and that'll tell you that although the system calculated a shear wave speed, when the computer looked at the information that it used to do that, it was not very good. And you should not believe those values. And again, this is mostly only occurs in breast, because most of the other lesions that we see in other organs are not as stiff as breast cancers. So again, the takeaway points are always try to move the patient so you get the best image. So again, trying to avoid the carotid artery when you're doing thyroids, which can be very difficult. Trying to get the patient changed, you can change their neck position to try to make the area as flat as possible. And again, applying not a lot of pressure. Another thing that we didn't talk about was if we do a cyst on 2D shear wave, I said simple fluid does not conduct shear waves. So you can see here that it's black on the velocity map. It's telling you it's like XXX on the livers. I couldn't count, the computer saying I can't calculate a shear wave speed. Now if we go to the quality map, you can see that that area is actually even bigger, that corresponds to the entire cyst, is yellow, telling you that the machine did not see good shear waves and don't believe any number in that lesion. So simple cysts that do not have any debris in them will not show you shear waves. If you have a complicated cyst that has some material in it, it will show up as a soft lesion. So you cannot distinguish with 2D shear wave if a lesion is a fibroadenoma or a complicated cyst. On strain imaging, this lesion will give us a bullseye, so we will be able to say it's definitely a cyst and not a fibroadenoma. Any questions on small parts? If not, we'll have Dr. Dietrich show you his technique for doing a liver.
So first of all, thank you so much to be our model. So very good looking, and that's good. So he might know me from yesterday, but if people go for a liver exam or for ultrasound, they might think that will take some time, and most people, if I would be allowed, are looking like that in a supine position, thinking what the doctor is doing might be good or bad, but it will take time. At least if he looks at his bill afterwards, it will be expensive. So he might think that was taking a long time. So for the shear wave elastography of the liver, we should optimize our patient, because pushing the button for a number is so easy, a monkey could do it. But the preparation beforehand, it's so important that we think and optimize our patient. First of all, what I've been telling was to know if that patient has what kind of etiology. He's healthy, but we would assume that he might have chronic virus hepatitis C. We assume it, okay? And our question before the examination would be if that patient has no fibrosis or low fibrosis or liver cirrhosis, because it will be different drugs, it will be a longer treatment, and we have to add ribavirin in certain circumstances. So we have a good answer which we get. Then, before we are doing the examination, we have been doing a physical examination, asking the patient if there is any congestion, any chronic heart failure. If the laboratory data are pathological, the transaminase is not enlarged, higher than normal values, because 5 times normal values will give you really bad results, inflammatory reaction. And then we start to interact with our patient. First of all, I will show you a few tips and tricks on how to perform liver ultrasound, and then I will show on how to do the point shear wave elastography using the Siemens system. But before we start, I'm a doctor and I need to work efficiently. That means if I start to optimize here and there and everywhere, I would lose time. So for almost all shear wave elastography, I have a certain approach. If you look to the FibroScan papers, they would say that in the mid-axillary line in a supine position you should measure. We will see right now what happens if we do so. And then we might take the second point. But first of all, I will start in that way that we look like we are recommended if we do the liver exam. Then we have to go for the right transducer. Thank you so much. So right now we are going, how to say, you might see, in the mid-axillary line. Yeah? And we get some sort of image like that. First of all, how to improve my image would be not to have, how to say, a depth of penetration of 16 centimeters, but to go closer. Okay? In an Asian person, you might go for 10 centimeters depth penetration. In an European, you go for 12. In an American, you might go for 28. No, that's a joke. But it might depend on the height of the person. Second, if I'm looking right now, in between the ribs, that I have a window right here of about 2 centimeters. It does not look too good. So there are a few things which I'd like to improve right now, because if I go for the FibroScan position, it seems not to work very well. And I would do it also for the FibroScan to improve my, my position. So what I do with the patient is I turn the patient a little bit to his left side. Okay. Second, I ask the patient to bring down the left arm. To be like a cat on one side, to get a curved thorax, we wish to widen the intercostal space. And now I'm doing everything to widen the intercostal space. Bring down this one. And normally the people, the patient is doing like that with the right arm. But I will, how to say, take a little bit more movements like that. He's a very friendly patient, and many patients in this position do not know what I'm doing. and they keep their knees like it is like here, and I have my elbow right on here to bring also this part of the body to widen the intercostal space to get a better window for the elastographic imaging. Okay, a little bit like that. Right now we will have a look if our window has been better to make point shear wave elastography. Recall that our window was about 2 centimeters, and right now it looks much better. So we have no more 2 centimeters, but our window for elastography widened to more than 6, 9 to 8 centimeters. So it was much better, and even we could do better. The enemy of the good one is the better one, so I will fight a little bit for the best position of the patient. In this position, you might see a few things. So you will see the portal vein right on in the center. Nice color. You see, take a little breath, stop. Take a breath, stop. Okay, you can nicely see the liver veins in the center of the screen. And the third interesting point at this occasion and at this position is that if I focus a little bit down, I can judge the quality of a machine. Here you can see the diaphragma. The diaphragma is not, as many people assume, a bright echo. No, the diaphragma is a muscle, and it's hypoechoic. And here you can see the muscle, the center fibrous tissue, and the other muscle. And if you see such echoes, you know I have a good ultrasound machine, a very good one. It's a good quality. But I'm not looking for the diaphragma. Take a little breath, a little bit. Stop. What I'm looking for is the right adrenal gland. And you can see the right adrenal gland always different from the diaphragma, which is here. And you see the adrenal cortex here, the hilum here, and the adrenal cortex here. And this is all in this position of the patient. I call it sometimes the position of 2 o'clock in the night. I'm on a night shift, and I have only one view to the patient, and I'm looking for different, how to say, emergencies. So I'm looking for the, okay, in this case it doesn't work, for the gallbladder. I'm looking for the air in the lung, the recessus costodiaphragmaticus. I'm looking for the Morrison pouch right on here to have free fluid. So this position of the patient and this, how to say, handling for shear wave elastography gives me quite a lot of information. Okay? So that is how I handle my patient. I don't do anything more. Most he is doing by breathing, taking a breath, take it out, or whatever. So that's a position, the best position, and it's much better than supine, and it's much better to work with the arms like that. You have a broader field of view. And then you push the button and you go for elastography. And 2 take-home messages we have to recall. Don't go for the first centimeter of the liver, and don't go beyond 6 centimeters of the liver. In the first centimeter, you will get 2 high values, and due to attenuation in the distal part, you get 2 low values. So right now we can, how to say, we can ask the patient the patient to stop breathing, or he can breathe in a mid position. But if I'm going to Richard and I ask Richard, don't breathe, what is Richard doing? He takes a breath because he does not know what I'm doing. So I anticipate not to tell do not breathe, because almost all people take a little breath on that. I'm anticipating what he's going to do, take a little breath. Okay? So that's a way to handle the patient and the people. So I do not know Vietnamese language, but he might take a little breath. Don't breathe. Okay, stop. Very good. And then we can update the value, and we can see the values on the left upper side, physically measured as it is correct. The velocity, most people all over the world use the kilopascal, so it's displayed quite nicely here with the Siemens system. One thing, if you have problems, how to say, sometimes in a lower intercostal space, and if you have the choice of this intercostal space or one higher, look like that, in practical experience, this compared to this is almost the better one to get the results. So if you are not sure about the results, you might go even one intercostal space higher, mid-axillary line, one higher, here we are, and even you might go one higher, it gives you sometimes better results. Think about that. And right now he should slowly breathe, and then we will have a look on how to measure. So the measurement will be taken, update, there will be a freeze, I defreeze, I give an update, 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 5-minute measurements in 20 seconds. So 10 measurements will give me, how to say, a time spot of about 60 seconds. It's a short period. And you might be thinking, why this stupid German does not take here a position, there a position, and here a position, and here a position in the liver to get more representative results. You might think about that. That's fine. But take 10 measurements in one point, 60 seconds or even less, and the next 10 you go to a little different place and look over there with 10 measurements. So you might go for that. The normal the liver, the more normal the liver, the more homogeneous the data, be sure. The more liver cirrhosis, the more fibrosis, the heterogeneous the results in the different part of the liver. That's what we learned. So the idea is, if I measure and I'd like to have 10 measurements, I'd like to have 10 measurements of one respective point in the best value. So I stay in one line, do my 10 measurements. If I do believe it's heterogeneous, I take a second point and give 10 measurements and see how it is different. So that's a way on how we do shear wave elastography. I've shown how fast that might work, and after a while the touch might even be faster than I've been doing this, and it does not take a long time. It takes 30 to 90 seconds to get 10 measurements. One question to the audience: is one good measurement the worst one compared to 10 bad measurements? one good measurement is better than 10 bad measurements, I would say. So always go for quality, take your time for a good position of the patient, do, optimize, and give all informations you might get into your personal, examination technique. And before I start, I do also a little bit of ultrasound, and I might show you one or two more tricks. I've shown you this position, will show you portal vein, right liver vein, right adrenal gland, Morrison pouch for free fluid. In many persons, not in his case, also gallbladder and the pleura. So you get in this position almost all information from this side which you need for an emergency care patient to decide if you can sleep further or you need to work. So also this positioning is of importance. Turn a little bit more to your side. Okay, but I need a little bit more gel. Okay. Right now I go out of optimize my image. Don't touch. Sorry. Take a deep breath. Okay. So right now I'm looking for the angle between the portal vein and inferior vena cava. Breathe normal. One more time. Take a breath. A little bit. Just a little bit. Stop. And breathe normal. Take a breath. Take a little breath, please. Would you ask him to take a little breath? A little bit. Stop. In the angle between the portal vein and the inferior vena cava, and you can see the common bile duct and the cystic duct. In this angle, you can see normal-sized lymph nodes up to 17 millimeters in a normal person. Here we have 40 millimeters. In patients with hepatitis, autoimmune hepatitis, virus hepatitis, those lymph nodes are always enlarged. And you can see them quite nicely using the B-mode ultrasound. So this is also in this position of the paper. At least he has exclusion of about 90% that he has no virus hepatitis or inflammatory liver disease. So coming to a conclusion would be, first of all, before a patient comes for shear wave elastography, ask for his current complaints, go for past medical history, look into laboratory data if there is any inflammatory activity, the transaminases or cholestasis. After exclusion, go for exclusion of congestive heart failure. All things which might influence the results. Then you start to do the liver scan, the spleen, go for ascites, go for lymph nodes, go for all that information. Position the patient, go intercostally as I have shown. Sometimes a little bit higher might give better results as lower. And then widen the arm enough, not too much, but enough. We have seen from 2 to 8 centimeters, we could have changed the window, tip and trick in the daily routine. And then push the button like a monkey, and get your results. So that's what I wish to explain. I wonder if you have additional comments, Richard.
So one thing, I always watch the V mode image when you're asking them to hold their breath, because they may take or change and you can see that the liver is moving when you do your measurement. So I always try to watch the B mode image. If you have a patient that is a hard time holding their breath, again, you can watch the liver as they're breathing going up and down and try to do your measurements always in the middle position.
I love very much to comment, just to say, transient elastography is done even independent of the respiration, okay, mid-respiration. Point shear wave elastography can be done in such a patient in the mid-respiratory, very small movements. It's quite nice. As you mentioned, for shear wave, also in other organs, you need to have no respiratory movements. So it depends on the machine, what you are doing. It might be a slight movement, transient elastography and point shear wave elastography. The more 2D, the larger the volume, the more time you need. No respiration.
The only other thing that he didn't mention was fasting. So it's very important that the patient should fast for 4 hours before the exam, because when you eat, you increase the blood flow to the gut, it goes through the portal vein, and it increases the stiffness of the liver. So we ask the patients to fast for 4 hours before we do the exam. However, our sonographers always come and say, oh, the patient ate, so I'm not going to do them. You can do the patient, and as long as they're normal, they're normal. If they eat, it will only raise the value. So what we usually do is we will try to do the patient, but if the values are high, then we let the referring doctor know that it may be artificially elevated and that they may want to send the patient back if they need to for clinical reasons to get a better value.
I love this comment very much because Richard mentioned 4 hours, and that's a practical hint. If you look for our guidelines, it's 2 hours. So the level of evidence which has been examined is 2 hours, but our consensus, practical feeling is not what has been published in the papers. It might be a little longer, the fasting period, and therefore this explanation. So,
my understanding from the literature is if the patient is normal, 2 hours is fine. But if they have an abnormal liver, it takes them longer. So we use 4 hours because we don't know if the patient is normal or abnormal when we start. So we try to do these like our gallbladder exams. They're the first exams scheduled every morning. So most people come before they eat breakfast, and we have snacks and coffee for them as soon as they finish their exam.
Thank you so much for your support. That was great. Thank you. Bravo. Yeah.
The standard report on your internet. We did for me.
Yeah.
Just describe that earlier for the liver
Yeah.
or for the breast.
Yeah. There should be a standard report, and in the Siemens machine you have the location number 1, you have focal lesion number 1, you have location number 2, number 3, number 4, number 5. You do 10 measurements and give that report. So a report is, I am examining a man in its best age, like you. It's, I would say 30 years, I do not know. How old are you? A little bit older. Okay, so a male, 34 years old, with the indication for the examination chronic virus hepatitis C. The transaminases are normal or are elevated. Cholestasis indicating enzymes are normal or elevated. Past medical history shows this disease, and there is no focal lesion, and there is no sign of congestive heart failure. In my report, all that 5 features are included. because they are important for the interpretation. Then I have my normal ultrasound report on the spleen size, no collaterals, no ascites, normal flow in the portal vein from intercostally in between 12 and 24 centimeters per second in the patient without any food intake in the fasting patient. This will be in my report as well. Then in my report will be the machine, the transducer, the frequency of the transducer used, the program, the depth of measurement below the liver capsule, how many valid measurements, the median of the 10 measurements using point shear wave elastography, and the interquartile range. That means the values from 25 to 75 from the median. 25 below, 25 up, divided through the median. It's given by the machine, the interquartile range. This should be below 30. No, in the healthy it should be below 10 because you get very good results. In the patient with cirrhosis it should be below 30. So all that comes to a reporting and should be reflected. And we had yesterday a nice discussion. Who has all that knowledge? The radiologist, the sonologist, the pathologist, or whatever. But by doing an interpretation of your report, think about all that information. I wonder about Richard, what you are adding to my comment.
So what we do is, obviously he's looking at his own patient, so he is more familiar with the patient. And when we report it, we report the stiffness value, the interquartile range. But you have to remember, we're measuring liver stiffness, not fibrosis. So anytime a patient comes and they have congestive heart failure, that they aid, we make a comment. So we say the liver stiffness value is 1.2 meters per second that corresponds to no or mild fibrosis. And then, but if he ate, I'll say the value may be artificially elevated because the patient ate. The value may be artificially elevated because the patient's liver enzymes are up. So we add a little comment because sometimes we're not doing it for the hepatologist, we're doing it for an internal medicine doctor, and he's sending the patient to us to decide if he's going to send it to the hepatologist. So if we think there's a problem because the patient ate the elevated enzymes, we put that in the report to say, although we got a number and the IQR is very good, it still may be, if you use the cutoff chart, you may overestimate the degree of fibrosis. And then there are many cutoff charts, so each vendor has their own, the Vsum has their own, the Vsum has their own, SRU, the Society of Radiologists and Ultrasound, has their own. So it's kind of up to you and your institution which values you want to use. So for the SRU, the Society of Radiologists and Ultrasound, which is the American radiology's thing, we don't like to give cutoffs for F0, F1, F2, F3, F4, because in the middle, like Christoph has been saying, we do really well in normals and we do really well in cirrhosis. In the middle, we're not so good at deciding if someone is F2 or F3. So we give two values. One value, the low value. If it's below that, they have no or mild fibrosis. One value, that is the higher value, that we say they either have severe fibrosis or cirrhosis. And if it's in between, we say they have moderate to severe fibrosis. So, and I think that's all we can do because there's so much overlap and variability between patients. It's very hard for you to say, oh, this is F2. So we don't think we can do that. And most of the time, what we need to know to treat the patient is, are they cirrhotic, are they normal, or are they in the middle? So we think that's a very good way of doing it. And the Vsum guidelines are going to come out, and we're discussing another simplified way to say rule in or rule out. So if you have a value that's very low, let's say below 5 kPa, we can say that patient's normal. If they have a value between 5 and 10, they have a very low probability of having cirrhosis. So we'll say, if you think they have cirrhosis, you have to do more tests to prove they have cirrhosis. If they're between 10 and 15 kilopascals, we say you have to rule out cirrhosis, that they may have cirrhosis, but you should do other tests to make sure they don't. And if they're above 15 kilopascals, they definitely have cirrhosis. So it's kind of a very easy way, and it works out nice, 5, 10, 15, 20, above 20 they have portal hypertension. So using that is one way that we're discussing, but those numbers work for transient elastography. We think the numbers need to be a little bit lower for 2D shear wave. Instead of 5, it may be 4. Instead of going up by 5, go by 4. But we haven't finalized that yet. But I think that's another easy way for you to know what the clinician needs to do, as opposed to saying it's F2. You know, you can say some people can have cirrhosis and have still very low stiffness values. So it's not just the stiffness value, it's putting everything together in one picture.
Thank you very much. Really like your idea about talk about a mild, moderate, and severe fibrosis. Because before I used F2, F3, I really don't sure.
So that is in the SRU guidelines. It was published in Radiology in 2015. If you want to look at it. If you want, you can give me your email address and I'll send you a copy. But that's what we thought. And I have some nice tables that show. Dr. Friedrich Rust did a meta-analysis with the Siemens system on several thousand patients. What we did is we took her data, and instead of doing cutoff values, we said, if you had a value of 1.5 meters per second, how many people were F1, how many people were F2, how many people were F3, how many people F4. So that's called the likelihood ratio. And you can see from the table we have in the book that, again, that normal people we can separate pretty well, and the cirrhotic people we can separate pretty well. But in the middle, it's very hard. Nobody has more than 50% for any value in the middle. So no matter what you call them, you have a more than 50% chance of being wrong. So that's what we think. So again, if you like, I can email you a copy.
Just to add the point of view of a hepatologist. If you have no fibrosis, good to know. If you have liver cirrhosis, good to know. If you have F2 or a little less or a little more, it's heterogeneous. I don't care. I'm not even interested. It's intermediate. Here a little bit more, here a little bit less. In the liver, here is hypertrophy, in the caudate lobe. So it's like that. It's intermediate. You don't give better values to a situation which is heterogeneous. If I would give a cut-off in a heterogeneous situation with clear cut-off values, I wouldn't say the truth because it's heterogeneous. I can't give a clear value. It's intermediate. I'm happy.
Thank you.
Thank you. I'm Maria from Indonesia, and I want to ask Professor Friedrich how we can examine a congestive liver, mild and severe in patient, and what the influence of congestive liver for elastography. Thank you.
So if I understand right, the second question was the influence of congestion. And in a patient with congestion, chronic heart failure, you might know a surgeon who is operating on a liver and he is touching the liver. If the patient has a high blood volume, it's stiff. And if the patient has a low blood volume, it's soft. So there's a big influence, and you cannot measure anymore because you are measuring the congestion. And you might recall in children, there was a question about children, they use it even for follow-up in congestive heart failure in pediatric patients after surgery. The first question, I have to say, I didn't clearly understand.
How to examine congestive liver?
Okay. To rule out congestive heart failure, you might do it KISS, keep it short and simple, measure pro-BNP and by laboratory data before you do stiffness values. That could be one way. And in certain circumstances, we are asking for that. Second, you could go for the echocardiography to have a look into the contractility of the heart. And that's the second one. The third one is I always look for the flow profile in the right liver vein. You might recall that I was looking for that. And the profile, if it has not 3, 2, or 1 pulsatile parts, but the fourth one in the wrong direction, then it's a sign of chronic heart failure. And the pulsatility in the portal vein, when the pulsatility is more than 40% in the portal vein, then you can be sure it's also a sign of congestive heart failure. So I have a few things. The take-home message is ask for contractility using echocardiography, look for pro-BNP in the laboratory data to exclude, and the other ones we add in our, how to say, examination. Do you agree? She is the only lady who has seen Bad Mergentheim by herself, where I'm living, so I'm proud to meet her.
Sir, in a hospital where we are working, assume a situation that if we are using multiple vendors ultrasound machines, for example GE, Siemens, Philips, and different companies have got different cutoff values for liver stiffness. So my question is like how should a doctor understand which vendor is accurate, or which values we should actually take into consideration for doing our interpretation? Because Siemens gives some different values, Philips gives some different values, Aloka, Toshiba, all companies give different values. So as a radiologist, how do we trust which vendor is more accurate or more precise?
I love that question, and it might take a little time to go deep into that. First of all, no of the vendors is right or wrong. They measure what they measure and they display what they display. To divide this question into a few, how to say, points. First of all, what is the gold standard of being right or being wrong? Finally, knowing, I have shown that image that if you have that fibrotic strand in a liver biopsy and you might catch it, you have liver fibrosis 4, liver cirrhosis. If you don't go in the same patient through the fibrous strand, it's F0, there's nothing. And it's our gold standard still. So we are going for a liver biopsy, and from an ethical point of view, most of the studies have been done, 90% of the studies using EchoSense, FibroScan. So right now we are not anymore allowed from an ethical point of view to have the gold standard of liver biopsy because we have that exempt. So the new gold standard for any kind of comparison will be FibroScan. This does not mean at all that FibroScan is correct or not correct. At least it has been compared with liver biopsy. It might be correct or even not correct, and we have seen that the ultrasound image will show us better results by point shear wave elastography. I'm only telling the story. Third, if you're using different equipment, go for published data, and there are tables from Richard, myself, and tables where you can find the normal values for each method. But be aware, I've been telling that gentleman, you have to introduce also the equipment, the transducer, the frequency used, because if you use higher frequency, lower attenuation of, there will be more attenuation of shear waves in the deeper fields. And then you should also eventually indicate the depth. So that would be a little bit of answer of your question.
So for the SRU, one of the guidelines is if the patient comes back for another scan, they should always be done on the same system with the same probe at the same depth. So the other thing is in the SRU guidelines, there's a nice table that has each vendor and the value. So you can look and see, oh, Siemens is always a little bit 10% higher than Philips. And it at least gives you an idea of which is higher or lower. But we always try to look, when the patient comes in, we see which machine we used and try to use the same machine. The values actually may change too if the vendor changes their software. So if they change their probe and the frequencies are different, you may have different cutoff values. So like in Philips, we probably will have different cutoff values for the point shear wave versus the 2D shear wave. So we don't have the studies out yet, but I wouldn't be surprised because they modified the probe to do 2D shear wave. So the frequencies are different, so the shear wave speeds are going to be different. So the only way you can solve this problem is to always do it on the same machine.
I love what he's telling. I would also add, it should be pretty much the same examiner. He and the patient both should have the same alcohol intake beforehand than the last time to compare the data. The mood and the time and whatever should be pretty much similar. So the comparison of data, let us be aware, is not such of clinical importance, first. Second, the circumstances when to measure seems to vary.